in this talk. And neovascular glaucoma, as we all know, actually is a potential blinding disease, and it often needs a multiple prong approach to treating it. We have to try and work on regressing the new vessels, reduce the inflammation by using anti-VEGF injections as well as laser wherever possible. And following that, treat the intraocular pressure medically, and where required, a surgical intervention is often required. The choice of surgical intervention lies between trabeculectomy with antimetabolites or a glaucoma drainage device. Cyclophotocoagulation is mostly reserved for eyes with poor visual potential. And I'm talking about primary trabeculectomy and with mitomycin C in such eyes. I know Dr. Aparna will mention that the outcomes of trabeculectomy in neovascular glaucoma is quite poor, and the older data from the 90s and all, of course, was quite poor. But when with antimetabolites, things start to look a little better. But thereafter, with anti-VEGFs now, followed by trabeculectomy with MMC in eyes where you do not have too much conjunctival scarring, the results are not bad. So I think that is an important message, that anti-VEGFs have changed how TRABs behave in these eyes. The success rate of TRAB depends on, of course, how well you've treated the neovascularization before intervening with surgery. Usually it takes about 1 to 2 weeks following the anti-VEGF injections, and good PRP wherever indicated. You have to titrate your mitomycin C concentration and also do a wider area of application. Releasable sutures also help in close monitoring postoperatively to intervene when required to maintain good IOP control. Just to look at the data, when you compare AGV with trabeculectomy with antimetabolites in neovascular glaucoma, in this study, you can see that over a period of time, at 2 years, actually the IOP lowering control was quite comparable, and there was hardly any between the two groups. Looking at the complications between groups, they were also quite similar. If you look at this very recent study, which is basically the TVT, neovascular glaucoma TVT study, here also you can see that the success rate was quite comparable in the Barveld as well as trabeculectomy group. And also the medication use, visual acuity and interventions were also similar in both the groups. They felt that the trabeculectomy group actually showed smaller numbers of late complications compared to those who had a tube implanted in their eyes. And tube exposure was a very common late complication in the other group. So just to say that trabeculectomy also is a standard care of procedure, which we are all very familiar with. So the familiarity of the procedure with the surgeons is an added advantage. The cost is taken care of, and you always have an option of implanting tube at a secondary stage if required. So just to say that many other studies where they looked at tubes and compared it with control groups, they felt that neovascular glaucoma eyes didn't do as well as the normal eyes with secondary glaucomas with tubes. So just to conclude, the complication rate also was a little higher in neovascular glaucoma eyes when tubes are implanted in them. And I would like to conclude to say that trabeculectomy with mitomycin C still is a very viable option in these eyes, especially if you've treated them with anti-VEGF and lasers before doing the surgery, especially in eyes where there's not enough conjunctival scarring or other risk factors like aphakia and all. Tube surgery primarily can be reserved as a secondary procedure in these eyes.